Just another second. All right, in the interest of time, we'll go ahead and get started. Thanks again for tuning into this week's e-lecture series presentation from the MSK section at Emory. Just some housekeeping items before we begin. As always, this webinar and all the webinars that are broadcast on here and on our channel are for educational purposes only. All of the interactive features have been disabled for attendees, and this is to ensure optimal quality for all viewers. If you have any questions, we have this email address here, emorymskradiology@gmail.com. We occasionally see people raising their hands, and that's really the only interaction available. But if you have a question, please feel free to email us here, and if time permits, the speaker today has agreed to do a question and answer session. If you have questions after the fact, I believe he's going to provide his email information, so you could contact him directly as well. This video will be recorded and uploaded to the YouTube channel. A reminder, attendees have not been given permission to screen record this talk or any of the talks on the channel, and this is because there may be material that's under copyright. Unauthorized recording, use, and distribution and sale of material without permission from the speaker is illegal. All right, and with that, I'm going to introduce our speaker today. Today we have Dr. Mark Mullins, who is a professor of radiology at Emory University with joint appointments in the departments of neurosurgery and neurology. He received his MD and PhD at Harvard University and then completed a residency in diagnostic radiology, followed by a fellowship in neuroradiology at Massachusetts General Hospital. He served as the Emory Diagnostic Radiology Residency Program Director from 2008 to 2015, and currently serves as the Vice Chair for Education and the Director of Radiology for medical students. He has held many leadership positions in national professional groups. A few examples include serving as the President of the American Society for Neuroradiology, on the Board of Directors for the Association of University Radiologists, as chair for the American Rank and Race Society Scientific Program Subcommittee for Neuroradiology, and as the president for the Alliance of Clinical Educators in Radiology. He has received numerous awards, has published extensively in a variety of high-impact peer-reviewed journals, written book chapters and reviews, and is well known for his educational neuroradiology lectures. Pre-pandemic, he was a regular visiting professor across the country and has since shifted gears to continue to provide high-quality education during these more challenging times. We are delighted to have Dr. Mullins speaking with us today, and with that, I will turn it over to Dr. Mark Mullins.
Thank you very much, and thanks very much for the opportunity. It's very kind of you. Okay, you see my screen?
Yes, we do.
Everybody's good. Great. Thank you. Well, thanks so much, Adam. Thanks, Emory MSK divisions. Awesome to be here. I really appreciate this opportunity. I'm glad to talk about this subject matter. This is something that if you do what we do, this is a daily sort of thing to pay attention to, right? So I remember a few years ago when I was looking up topics of headache and imaging of patients with headache and imaging of patients with back pain. And I was thinking, you know, you'd be lucky if you're a human being and you don't have either one of those at some point in your life. Spine surgery is it's a smaller group within that, but very common, right? Very common. So this is if you end up reading spinal imaging, CT scans, MRIs, radiography, this is kind of like, you know, going to be there, right? So it's one of these things that you want to get a good handle on. So let's take a look at this topic. Here's my email address. Shoot me an email if you want to. I don't have any conflicts of interest to talk about with this subject. All right, so hopefully I don't have to motivate you too much just in terms of how commonplace this is. Making a great diagnosis is going to be helpful, obviously, to not only for that patient, your referring physicians, but it's going to be good for their practice as well. And so that's the goal, right? To make a great diagnosis, figuring out did the patient get the imaging, which will show the diagnosis that you're looking at the most, right? And so focal point wise it's really good to try to figure out what the question is. Maybe, hopefully there's a question to be answered. And one of the things I like to focus on with my trainees is making sure they understand that the drive should be towards answering the question at hand. Sometimes, unfortunately, there's not a specific question, and then it becomes more of just, describing what's there and seeing if there's anything unexpected, anything concerning, things of that nature. Why do we care about these diagnoses? Well, first of all, it's useful to know what's going on for yourself, for your patient, that kind of stuff. But in addition to that, treatments exist for some of the situations, and it may affect how the patient is managed. So said differently, when I look at a case, I try to go as far as I can to understand exactly what I'm looking at. And sometimes that means additional imaging, additional type of imaging, maybe additional sequence, talking to the patient, talking to the referring physician, blood labs, things like that. And I do what's called a chart biopsy to sort of look in the chart and figure out what's going on that's relevant to that scenario. And then I pivot. Once I'm done and I go as far as I can, then I pivot and figure out how I can help take care of that patient. And so hopefully the motivations are strong there to figure out doing the most good for the most patients and helping individuals as well as groups of patients as well. All right, so I'm big on quality, safety, utilization, and appropriateness. There isn't part of the ACR appropriateness criteria that's specific for this area, but here are some areas to think about. So chronic neck pain, focal neurological defect, low back pain, myelopathy, excluding trauma, ACR appropriateness criteria, and gave you the reference point last accessed here in 2017. So here is the URL. I will say that in general, there's this concept of red flags. So is there something going on, not only about a patient with back pain, certainly that's a big focal point, but that would include theoretically people who've had surgery as well. Is there a red flag about this scenario that makes you concerned that something more sinister is going on? And you see that there's some infographics as we go, and just to show, thank you to Nadia Advance for these infographics. So showing you here some weightlifting. All right, CT versus MRI. Now, of course, we're going to look at soft tissues and bones on both CT and MRI. There are the usual pros and cons, but as you start out, if my focal point is going to be on bones, then I'm typically going to start with a CT. If my focal point is going to be on soft tissues, start with MRI. CT and MRI have both gotten better and better over the years. You can see structures and characterize structures that maybe years ago were maybe not as well characterized. And I'm sure that's going to continue for some time. The pros and cons are usually, what they are. I'm not going to belabor that because I would guess at this point you understand it. Big picture wise, CT is easier to get to, and safety profiles, I think, favors CT just a little bit better. Like, for example, some patients can't receive an MRI because of absolute contraindications, sometimes relative contraindications, those things, that kind of thing. In general, CT costs less than MRI, so that's one thing that differentiates these two. And then, of course, artifacts can be found in both, and we'll talk about that a little bit as we go forward. Contrast material, we'll talk about in a minute. Let's talk about MRI safety and artifacts for just a second. If a patient has a device, we should know exactly what kind of device that is, if at all possible. So if someone put it in, somebody should know what it is, and then look up that device specifically, company name, device name, lot number name, those kind of things at a reputable source. And I can't tell you how many times that I've spoken to a patient who swears that they had an MRI when they actually had a CT. And then, the other thing is people will talk about, well, I had an MRI and that went well. Just because it went well once doesn't necessarily mean it's going to go well again. It could have been difference in field strength, or there could have been extenuating circumstances. You just don't know, right? So you want to go back to first principles and start from a position of safety and go through that. Now, once you've figured out that they're MR compatible, then you pivot and say, well, how much artifact is going to be in there? And I've seen it amazing. I've seen tiny amounts of metal have huge artifact, and huge amounts of metal have very little artifact. So you never know till you try. Again, assuming that you're safe to start with, right? So starting that part of it. And of course, in the modern era, one of the things that's really helped with this is titanium alloys. So better life through chemistry, as they say. All right, talking about 1.5 versus 3T. I think for most of what we're doing, 1.5 is just fine. I would practically, for all intents and purposes, always like to have a very highly optimized 1.5T versus a poorly optimized 3T. So just having 3T doesn't in and of itself mean it's going to be better. So of course, that's going to improve your signal to noise. And if you were doing some interesting things like spectroscopy, which I doubt that that would overlap this subject matter very much, then I mean, there's some things that I could say 3T would be better at, but for what we're talking about, I think 1.5T is fine most of the time. Now, of course, there might be some detail that you want to get the 3T for, and I totally get that. It kind of just depends on the scenario. Contrast material, we talk about contrast material here for a moment. And I'm just going to say that in general, we give contrast material for MRI for patients who've had prior thoracic and lumbar spine surgery, but not as much for cervical spine. Of course, that changes if you have a reason to give contrast otherwise. So for example, if they have cancer, they have a tumor, things of this nature, and in general terms, talking about neoplasia, infection, that kind of thing. But why is it that we typically give it for T-spine and L-spine? We don't give it as much for C-spine. Well, I'm going to get into that a little bit later. For CT, kind of depends on the scenario. If I have a patient who can get a CT and an MRI, then I'm typically not going to give contrast for the CT. If my patient cannot get CT and MRI but can have the CT, then I might consider giving contrast depending on the scenario. So it just depends on how you do that. And of course, we're talking about intravenous contrast material here. The usual sequences are pretty straightforward. What I am going to talk about just for a minute are fat saturation and axial GRE. I will say that axial, so people say that truth in terms of narrowings, it lies somewhere between GRE and T2. In my experience, what happens is, it's hard to interpolate between these two. And so in reality, what you end up doing, again, I like to operate from a practical and pragmatic point of view. But like you look at it and say, I'm going to work on figuring out what it is relative to something that is something that I see over and over again. So axial T2 is pretty ubiquitous. So leaning on that is one of those things that can help. And people say, true stenosis, the GRE probably overestimates and the T2 probably underestimates. But you just have a frame of reference as you go through it. Fat saturation can be super helpful, but the penance for using fat saturation is making sure that it's pretty homogeneous. If it's inhomogeneous, then that's a problem, right? So it's heterogeneous, that's a problem in terms of figuring out if it's there, because you'll see high signal and you might think that's real enhancement when maybe it's just a lack of fat saturation. So you have to make sure that that looks pretty good. Of course, if there's hardware in place, that can make things really difficult because of susceptibility artifact. Thoracic imaging, you don't always have the axials to go along with it, but you do, usually have the other sagittals. And again, the approach is to characterize things on the sagittals. Again, the classic thing, sagittal T1, sagittal T2, and a fat saturated T2 to correspond with each other. STIR or T2 fat sat for the sagittals. Both have their positives and negatives as far as that goes. I will say a lot of people now lean towards always getting the axials, but it's not always there. It's not ubiquitous in terms of thoracic spine, but it can be useful. And then in terms of the lumbar spine, again, a little bit of a focus in adding the axial T1s in there. If you're going to do post-contrast imaging, usually the axial T1 pre gets in there so you can tell if it's true enhancement in doing the post-imaging as well. This is an infographics that I asked them to make just to talk about, in terms of the pattern of radiculopathy and looking at the dermatome map. The dermatome map is ±1 in the normal human. So if you get somebody and they say there's a right L5 radiculopathy, the right L4, L5, or S1 nerves could be adversely affected. So ±1 in the normal human. And when you're trying to figure out if what you see on the imaging is fitting going along with the patient. And this just shows, disc herniations, talking about the nucleus pulposus here and the annulus fibrosus. anterior, posterior, right and left. And so anterior disc herniations don't get a lot of love, but they can cause pain. Lateral space tends to affect the exiting nerve. The infraforaminal ones tend to affect the exiting nerve. Posterior paracentral tend to involve the descending nerve in the lumbar spine, and then posterior central may involve the descending ones. But of course, the bigger ones can affect cord, conus, cauda equina, as can these. So it's useful to kind of think about this and think, okay, these are the areas in which I'm going to look if the patient has particular kind of symptoms, which leads me back to when I do my chart biopsy, trying to figure out if they have a radiculopathy and where it is. So for me, when I read spine, the big three for history for me, do they have a history of cancer? Do they have a history of surgery? And do they have pain? And if they do have pain, is it radiating? If so, where? You know, those kind of things. And it leads me to be set up for success. And as you can tell, I'm like a top three pick one kind of person. So I kind of focus on that as I go through it, and it gives me sort of a setup for trying to figure out what's going on. And if I go through a scan and I can't find something that explains the patient's presentation, then I go back and look in particular areas and think about where I might have missed something. And on the first pass, and then try to see it on the second pass, knowing to look in a specific area. So let's do a quick pre-test and show you just a few questions here. We will look back at these at the end. Now you can see why I didn't discuss this just yet. All right, so 5 pre-test questions, and we'll jump right into a case. So one of the things I just want to try to solidify for you is the idea of why we give contrast material to the typical scenario of somebody who's had lumbar spine surgery. You can see that the patient's had a laminectomy here, at least partial laminectomy there. And so you have a target here, you have a target up here. So this is probably your primary target, given that it's at the surgical level. And then you look at it, and the characteristic way that we do this is to look at the T1, look at the T2, the sagittals, then characterize it on the axials. And I'm going to tell you, it pushes down, it pokes down. And the question is this a disc extrusion, or is this granulation tissue? And I'm here to tell you that you don't know until you give contrast material. And basically, that's the primary reason why we give contrast material to somebody who's had a thoracic or lumbar spine surgery, is that you don't know till you give contrast material whether this is granulation tissue or not. It can look exactly like a disc herniation and solidly enhanced, and that could be granulation tissue. And so that can fool you. So just remember, if you read a non-contrast one, to go back and think to yourself, okay, well, that could be either way. And theoretically, that's a big change in management, right? If they have a residual or recurrent disc herniation, they may go back to surgery. If they don't, if they have scar tissue, they typically won't go back to surgery. So that's usually how it works, and it can have a big change in management. And here at a non-surgical level, you can see another area with high intensity zone, and trying to sort out, that may be a disc herniation, it may be granulation tissue. It isn't just at the surgical levels, for that, but we're focusing on the surgical levels as well, and there might be a little bit there as well. So we go on. This is the T2 fat sat, and then you go on to the sternum. You can see a very small amount of disc material and a larger amount of granulation tissue. And of course, some of this may be reactive, but it looks like quite a bit of granulation tissue around this area. So not a great target, even though prior to contrast material administration, it looked like not a horrible target. And so you look at that and look up here, and you can see that you see enhancement around this collection of disc material. So there's a small disc herniation as well, just in the same patient, predominant granulation tissue and predominant disc herniation, in this case an extrusion with cephalad migration right there, a small one, admittedly. And don't forget that high intensity zones can enhance, that kind of thing. You'll see them as well. So this is a good way to sort of characterize it. And then you look to see if there's mass effect. There is positive mass effect there as you go through it. So in this patient, we see that there's space occupying process adversely affecting this exiting nerve root. There's the exiting nerve root on the left with, you can see this is lumbar level, and the ganglions right there. And you can see this, there's a lot of something as it sits there. Is it granulation tissue? Is it disc herniation? You really can't tell. Give contrast material, you can see a ring enhancing collection there. That is a disc herniation adversely affected. Now, you might say to yourself, could this be other collections? Could it be an abscess? Technically, it can be. It can be. It could be other collections, synovial fluid, all sorts of stuff. But in my experience, abscesses tend to be convex, and then clinically, hopefully, someone would be suspecting infection. But it is something to think about. They can be other collections, and then clinically, you want to figure out clinically what's going on with that patient. But if they don't seem infected and the referring physician is not too worried about it, it doesn't look convex, then the likelihood of that being an abscess is low. Never, and one thing is I practiced long enough to learn, never say never, never say always, but still very unlikely and probably a disc herniation kind of fits nicely. All right, so switching gears a little bit, talking about evaluation of the postoperative spine. If patients have surgical hardware, we'll talk about that here for a moment. And if they don't have hardware, of course, you're looking for patterns of disease. So things that would be early complications, hematoma, things of that nature. Maybe they developed a fracture as a result of the surgery. Maybe they have a dislocation, things like that. If you ever find blood where it shouldn't be, make sure you try to figure out what kind of compartment it's in, and then figure out what is causing it, if at all possible, and what it's adversely affecting. So cord, conus, cauda equina, things of that nature, exiting nerve roots, that kind of thing. I'll say in passing, I think that the exiting nerve roots are probably, they get, overlooked sometimes in terms of adverse effect by, say, tumor or blood or what have you. And a lot of times a patient may come in with radicular symptoms, and that may be an issue, and that may be actually why they came in is pressing on those exiting nerves. So pay attention to those as well. I like to say a smart person learns from their own mistakes, a really smart person learns from other people's mistakes, and pay attention to that. So we put in hardware. Generally speaking, obviously what's happening here, you've got transpedicular screws, you have posterior rod and holding them in, the back here, but rods on each side. For the transpedicular screws, you want to look and make sure they're covered by bone all the way around. And if they're not covered by bone, then where does it go, right? This is outside of the bone, next to the bone. You can see things of that nature. Does it go inside the canal? Yes, a little bit. Yes, a little bit. Does it go in the neural foramen? Yes, a little bit. Things of that nature. So you want to know where it goes, and you want to talk about that. And then on this kind of scan, try to glean whether you're worried about spinal cord, conus, cauda equina, nerves, that kind of thing, in addition to that. So you're looking at that. And this is, when we're talking about postoperative spine, this is in the immediate postoperative time period that you're looking for. In addition, as well, you want to look for those other things we talked about without the hardware there, hematoma, fluid, that kind of stuff. One caveat is that if you image a patient very soon after surgery, it can look really bad in terms of like, blood and fluid and that kind of stuff. And I've seen situations where patients have had scans early on after discectomy, and that for one reason or another had a scan very early, and it looks like the disc herniation is still there. That can happen. It takes some time for that stuff to abate. Clinically, I think is a good way to figure out whether things got better or not. Then you could ask the question, why did they get imaged early on? And that just depends on the scenario. That's a unique situation. So apropos of what we were talking about a few minutes ago, these screws go into the intraspinous canal. You would be worried about the spinal cord. I can maybe think maybe I see the contour of the spinal cord there, but maybe not. So it's hard to see. But I would be worried about the spinal cord in this particular situation. So I'd have a low threshold, not only to think would MRI help here, but first things first is talk to the referring physicians and see, are they worried about this? And of course, you would also worry about CSF leaks and some other things as well. More down the line, so not in the immediate postoperative period, not in the short-term postoperative period, but in the delayed postoperative period. Now we'll look at hardware and think, yes, we're going to still look and make sure that all of the screws are covered by bone. And as we get down into the lumbar spine, I've seen on occasion screws go through the S1 anterior table, and I've had surgeons tell me that they're okay with that. So that's the one area in which it doesn't bother me so much. Depends on the surgeon, depends on their intent, that kind of stuff. But then as you come up here, we notice one of the things we're looking for, right? So we look to see, is there anything that suggests that this hardware is complicated, right? So look at the scanograph for your CT. It's like an X-ray, and look to see about that hardware. And we'll pivot here and talk about hardware itself in a minute. But another thing is that a fusion surgery like this, the alignment shouldn't change. And if the alignment changes from a previous exam, you have to wonder if the hardware has failed in and of itself, right? You have to worry about that. And then, of course, having this hardware here is going to create increased mechanical stress effect above and below this area, because you hope that it's going to function as one area. And in my experience, in the lumbar spine, there's more of an issue caudad, and in the cervical spine, there's more of an issue cephalad, and you kind of go through it. Anyway, when you see the hardware, then you're looking to see if you see peri-hardware lucency, which is what you see in this case at this level, not so much at these other levels, but at this level. And then a primary differential diagnosis for this is loosening, granulation response, and or infection. And so those three are usually on the differential, and that's what you're looking for. So again, I'm going to encourage you to look at the scanograph for the CT, use it like X-rays to complement, the rest of it, and then try to get your mind favorable to recognizing clues that there are complex situations going on. Broken hardware can be, all sorts of different ways. These rods, obviously this was for a scoliosis survey, we've got some broken rods here. And it can be very difficult to see on MRI. It can be very difficult to see. And then on CT, sometimes it can be difficult to see unless you're looking. If you have a big gap like that, it's a little bit different. But a lot of times, you need something that looks like a scanograph, and that's what this is. This is a scanograph for the CT, and you can see that they're there, and that can help you a lot. Vacuum phenomenon can be useful. Vacuum phenomenon, to my understanding, is usually from motion. And so obviously, they say it's nitrogen gas being pulled out of the adjacent soft tissues from the pressure, negative pressure there. And so it's a sign of motion. And if somebody develops vacuum phenomenon at a level which should be fused, then you're worried about, again, that area not being fused, right? So there are little clues like that you can put together as you go through it and figure those things out. Obviously, later on, you want to see if there's solid osseous fusion. Sometimes it's partial, sometimes it's total. And then, it can be in different areas and those kind of things. So you're looking for that as well. And migrating hardware, see if hardware is in the right location. If there's a spacer or something that people put in, making sure that it's covered by bone above and below. So ultimately, it's the same kind of concept as the transpedicular screws when you look through and you say, is it covered by bone above and below? And then look and see if it's moved as compared to a prior examination. So something to pay attention to. In this same case, you might have noticed this fluid collection down here, and the same patient has, this is the thecal sac, and it's compressed by this fluid collection. In this case, there's no attachment here at the dorsal aspect of the disc. You can see with the exiting nerve roots right there. And so this is going to be a subdural collection. There's the exiting nerve kind of penetrating that area right there. If there was a so-called draped curtain sign right there, this would be, there you would be thinking about an epidural process. Another thing about subdural is typically you can't go all the way around, that kind of thing. So in this case, what is this fluid collection, right? So there's all this instrumentation. We don't quite know, right? I mean, could it be infected? I mean, theoretically, it could be infected. We want to know how the patient's doing clinically, kind of figure that out. It doesn't look like blood, but why not? Well, blood doesn't usually tend to be so homogeneous, but it could be. I mean, that's theoretically a possibility. Kind of depends on the scenario. And then very commonly people, not commonly, like if you see a fluid collection like this, more commonly, you're going to see that it's related to fluid that's gathering after surgery, maybe CSF leak, maybe, maybe it's going to be fluid from the synovial joints, like things of that nature. But still, you've got to run through your differential and try to figure it out. One thing I see people leave out that I try to encourage them to mention is the fact that this causes form-fruste centrocanal spinal stenosis. So form-fruste just basically means the same thing in a different presentation, like a different look to it. And so the cauda equina is going to quote unquote feel this, right? It's going to feel that compression, even though the thecal sac is not being compressed by bone or osteophyte or disc herniation or that kind of thing, but rather by this fluid. And you might say, well, the fluid's soft, and it probably is, but the patient could still have symptoms from it, and it could still be an issue. So you can look at that as well. All right, so talking about the cervical spine, we'll go up here for a little bit. You can see that this patient had surgery recently. They put bone graft in here, and over the course of time, you want to look and see if the bone graft has been incorporated solidly so, or is it still in pieces? Has it been resorbed? You know, those kind of things. When you look at the posterior fusion attempt here, again, you want to see if any of the hardware is uncovered there. And then here, there's solid osseous fusion, your plate and screws. And in general, the idea here is, I've heard the surgeons tell me they like to see the screws diverge in all directions, and that way it kind of digs in as the person's cervical spine moves, and it kind of makes sense. If they go straight in, you know, maybe doesn't dig in as well. And then, you know, oftentimes, you know, they'll put in a spacer here, and then the hope is that it'll fuse it all across the spacer. You can see the patient had a posterior decompression as well. The usual scenario here would be that the patient had stenosis ventrally and dorsally. Ventrally, usually from disc osteophyte complex in the cervical spine, and then dorsally from facet joint arthropathy and/or ligamentum flavum infolding. That usually is how it works. And this kind of surgery, if they do it at once, I've heard it colloquially called a 360. Do one of the surgeries, then flip the patient over and do the other surgery, and then you kind of are looking at it, figuring out, you know, okay, what did they do, and figuring out if there are any surgical misadventures as well. And then looking in, and don't forget at some point what I call turning on the lights and switch it over to the soft tissue windows and look inside the intraspinous canal and see, do you see anything in there, and some axial imaging showing that, you know, the hardware here is completely covered by bone. So that's good, right? And so this is covered by bone above and below. In terms of infections possible practically, I mean, you know, practically anytime from surgery, but usually the chances of someone, you know, leaving the OR infected are low unless they went into the OR infected, right? That's low. Usually it's going to take at least a few days to have those early infections. And I've been told you have to worry about infection forever, right? The theory is, you know, if somebody's had surgery, you think about it forever. So always think about it, and then always think about the compartments that are involved. And so when you look here, it looks like sort of the classic way we look for a space typical infection in an adult, discitis, in this case, probably frank abscess within the disc, and then with extension of abscess outside of this compartment, including in the epidural space. But once you give contrast material, you notice most of that solidly enhances, so it's kind of hard to sort out when you look at that. But this is also transspatial. Whenever you see an infection in this situation, figure out all of the infections that are present and mention them. So some things will change management. So for example, I've been told that if you see someone with osteomyelitis, the length of time that they'll be on IV antibiotics will be longer. So those kind of things. And then, you know, if the patient looks like they're infected inside of the intraspinous canal, that would be meningitis. And so like inside the with fecal sac rather, be meningitis, and so that may change management as well. So on and so forth. And if you're wondering to yourself, is it hard to figure out what's granulation tissue and what's not? Yes, it can be very hard to figure that stuff out. And so if you can't figure it out, just say, you know, either or, and try to sort that stuff out. And of course, on the follow-ups, unfortunately, you know, you don't have a lot to follow other than edema and enhancement. And sometimes, unfortunately, that can look worse, even though the patient may be a little bit better. So factoring in the patient's clinical scenario can be very helpful as you go through it. With hardware in here, this patient has developed a fluid collection. You can see this is not a simple fluid collection, so not a simple CSF leak, as in pseudomeningocele, but could be a hematoma, could be complex CSF, like CSF with something admixed with something else. Could be synovial fluid, although this is a lot of fluid for synovial fluid, but it certainly could be. So you want to think about, you know, what those things are. I like to look and see about convexity, because that tells me it's under pressure, and then I worry about like an ongoing process, a progressive process. So for example, I'm worried about maybe they're continuing to bleed, or whether they're infected, and that kind of thing. And you see, of course, there's some mass effect there, the complete effacement of CSF. So this is what I would refer to as severe central canal spinal stenosis. Of course, it's catching the distal aspect of the spinal cord and conus, and so on and so forth. Other kinds of infection around here, In general, right, you see something that's convex, it's a fluid collection, you've got rim enhancement, you're worried about infection, including abscess. You typically expect to see some complexity in here. And of course, this is centered on hardware, so you'd be very worried about infected hardware. In general, if there's an area you think is infected and there's hardware, then you might have infected hardware. And I know that's a big deal, but first things first is figuring out, like, are you concerned about infection? And here, I would be concerned about infection because of the convexity, because of the rim enhancement, whatnot. And with a collection this big, I would be expecting the patient to have symptoms from it, signs, symptoms, that kind of thing as well. And then make the point that it looks like, the hardware, if the way I would usually say it in a report like this is, if this is infected, then I would worry about hardware infection. Furthermore, in a case like this, there are a bunch of joints in this area as well. You could have infected joints as well. Again, things that would change management, things that are important to distinguish and differentiate versus those other things. One of the things that can develop from practically any of these surgeries is adhesive arachnoiditis. You can see here that there's clumping of the cauda equina. There's some ways that, some of the signs that we learn in training, like the empty sac sign. I've seen it a few times, but I've seen this a lot more often where things are just clumped together. And this is a sign of adhesive arachnoiditis. And you might say, well, could this happen even if they don't enter the thecal sac? And yes, the answer is yes. And I've seen it. And then the question is, did they get into the thecal sac inadvertently? Who knows, right? We don't know. So basically, the short version of that is you can see it even if the thecal sac has not been known to be violated, right? So it's a thing that can be seen. So you can have that. This is one of the ways to do it. Another way is the empty sac sign, where everything's plastered to the side. Imagine if you saw just CSF here and you didn't see it because the nerves were plastered to the side. So something to pay attention to as you're looking at these cases as well. Enhancement within the thecal sac, cord conus, cauda equina, in this case, the cauda equina. It may be from previous compression. If you don't have post-contrast imaging from prior to the decompression surgery, it may be left over from that. I've seen that with spinal cord, not infrequently. And then people will say, well, how long will it last? And the answer is, I don't know. It kind of depends on that scenario. It may last for a long time. It may go away. I've seen both happen. So there's that part of it. And of course, what you're worried about is that you would have another diagnosis that's there. Maybe they have an infection, maybe they have a tumor, maybe they have something else that made it enhanced. You don't want to blow that off. You want to think about those possibilities, even though not commonly the case. Of course, if you have pre-contrast imaging and then you have post-contrast imaging pre-surgically, and you get, you see the enhancement, and then of course let's say you don't see enhancement prior to surgery and then you see it afterwards, then of course you're thinking about these other things, thinking about the time frame. Is infection possible? What about granulation tissue? Like that kind of stuff as well. So certainly that can happen, and it can be a complicating scenario. Finishing up a few other topics here. Compression fractures and vertebroplasty. You can see this patient has a burst type compression fracture, has retropulsion here, so burst type compression fracture, and they've received either vertebroplasty or kyphoplasty. In my experience, I can't really tell. I don't think people can reliably tell the difference between vertebroplasty and kyphoplasty on imaging if they don't know, right? So you just look it up, see what the history is, and see which one fits. You see this embolization material. The hope is that it stays entirely within the bone. If it goes outside of the bone, then where does it go? You can see a tiny little amount goes right there, tiny little amount, and then hopefully then they figure it out as they're doing the instrumentation that it's going where it shouldn't go, and then stop. So there's that part of it. Once it goes outside of the bone, then it could go a lot of different places. So you kind of focus on that. And then you look to see, are there any other complicating factors? And if you've looked at enough of these, you realize that it's very common for the patients after this kind of procedure to develop mechanical stress effect above and below sites like this and end up with more compression fractures as well. And it's not clear exactly why that happens, but maybe multifactorial probably, if we had to guess. All right. One other technique that theoretically can be useful, I did show you here, patient with spinal dural AVF, so not a post-operative sort of situation, but just show you myelographic image. They can be helpful. So when I was in training, we did a whole lot of myelograms. Was the era where MRI was really coming on and replacing a lot of myelograms. And we typically do the myelograms now when the patient can't get an MRI, or there's a question to be answered in terms of a leak, things of that nature. And so usually problem-solving examination. The most interventional we've gone to this point is starting an IV, right? So doing an MRI or CT with contrast material. This, of course, requires accessing the CSF space and putting in contrast material. And it is obviously a little more invasive, but it's something that can be useful depending on what the scenario is. As a tool, one of the things that you can think about is if a patient can't get an MRI, or the MRI is adversely affected by hardware and can't see what's going on, sometimes doing a CT scan with IV contrast can help a lot, especially if the question is cancer and the patient might have a level and you're trying to decide, what's going on. That, of course, can be similar for post-operative situations as well. So that can be useful and be complementary. Let's go through these questions on the post-test. Given the scenario, I'm not going to ask anybody to answer it. And a good way for me to lose a lot of you is to read to you, so I'm not going to read to you here. Give you just a second to look at it again. All right, so protocoling is super important, trying to figure out how you want to do the best job for this patient. And theoretically, for lumbar spine with a history of laminectomy, we would want to do with and without contrast. Why? Well, we want to do with contrast because if we see a target, we would want to know if it's a disc herniation, residual or recurrent disc herniation, or is it scar tissue. That would be the primary reason to do it. And to compare it, to make sure it's true enhancement, we would need the without contrast. So that's basically in the nutshell. Now, I've seen a trend from our referring physicians to do less of the post-contrast imaging in this scenario. And I'm fine with that as long as everybody remembers the scenario that if we see a target, we would need to equivocate that, it may be a disc herniation, it may be scar tissue. And as we've seen from some of the cases we've looked at here, it could be a mixture, right? It could be any kind of mixture in between. So just something to think about. If the patient is not going to have surgery again, no matter what, then, I don't necessarily think giving contrast is absolutely required here, right? So, you might say, well, it's a disc herniation versus scar tissue, but if the patient's not going to go back to surgery anyway, you might not be worried about characterizing it, and that would make sense as well. So it just kind of depends on the clinical scenario and what's on the table in terms of opportunity. All right, so cervical spine, different, right? So let's talk about that for a second. We would do this without contrast typically. Why? Well, for some reason, granulation tissue, symptomatic granulation tissue is not so common in the cervical spine. Don't know why. It's just a thing people observe. So I don't think it's wrong to give contrast in this situation, other than to say that symptomatic granulation tissue is not usually a problem in the cervical spine. And theoretically, you can always bring that patient back and give it later. So I like to do these without contrast, and that's just kind of like where I like to do it. Obviously, if there are extenuating circumstances, known or suspected infection, known or suspected malignancy, so on and so forth, other reasons, that's different, right? So things change, but everything else being equal, that's typically why you do it and how you do it. All right, so what's causing this patient's right radiculopathy? We can see that there's a space-occupying process here. And when we give contrast material, it has rim enhancement. So basically, in this case, we have a space-occupying collection. It's adversely affecting the sectioning nerve root. I can't see the nerve root directly, but it's right where the nerve root should be. That's a good way to say it, in the expected location of that. And it's filling this, it's causing, severe neural foraminal stenosis there. Anyway, disc herniation is a collection that would fit that. Granulation tissue should solidly enhance. There are situations in which you could, like if you image somebody a long time later, like an hour later or something like that, theoretically, this contrast could seep into it. Perineural cyst, well, not with all of this adverse enhancement around it, right? It does make a lot of sense for that. A synovial cyst, not as commonly looking like this, and typically has points towards the facet joint. And I've seen them in the neural foramen before, but usually they point towards the facet and kind of a different look to it. Even if it was a synovial cyst, it would probably be an inflamed or infected synovial cyst, given that much adverse enhancement there. So everything being equal, probably disc herniation, right? Yes, it could be abscess, it could be a lot of things, but it's probably a disc herniation. All right, and again, not solidly enhancing, doesn't look like predominant granulation tissue. Okay, so we look at this and we see this lucency around the bone. What sign is most worrisome for infection? And that fits, right? Perihardware lucency. Disc narrowing, that is present, and that would be DDD, degenerative disc disease. In-plate irregularity, this is discogenic degenerative in-plate change. These don't look particularly infected, so present there as well. They did have a fusion surgery. That doesn't in and of itself make me worried about infection, but they do have perihardware lucency. That would make me worried about infection. Obviously, there's a differential for that. You mentioned those other things, but it's one of the things to remember. And what's the best interpretation here? We have a patient with scoliosis who's received paraspinal rods, and we see discontinuity, discontinuity, discontinuity. So that's broken hardware. And it's definitely not a typical post-operative appearance in and of itself. Now, as to whether they're going to do anything about it, who knows? But you give them the information and point things out to them, and then they get the information they need and they can decide what to do next. All right, so in terms of what we were talking about, if you remember nothing else, I'll be sad, but if you remember nothing else, what I want you to do is focus on trying to figure out with the patient you're looking at, with that scan, go as far as you can about understanding what you're looking at, history, what other prior images you have, those kind of things, other sequences, what have you. Is there anything that is not there that you'd like to have to suggest as a next step, those kind of things. And then pivot and think about how to help take care of that patient, right? So thinking about that, and with the take-home message that granulation tissue and scar tissue, granulation tissue and disc herniation can look the same up until the time you give contrast material, assuming that you image early on. Again, if you wait a long time, they can look the same. They can both enhance. But if you image early, then the granulation tissue is a collection of nucleus pulposus, and will have enhancement around it, whereas scar tissue should solidly enhance. And again, you can have a mixture of these two things as well. And in a lot of situations, this can have an effect on how the patient's managed. So thinking about that. Have an organized approach to it. It's one of the things I love about spine imaging is if you have an organized, logical approach, you can just kind of step through it and look at it. Checklists are hard. You notice I didn't give you a checklist per se. Checklists, to be super useful, in my experience, need to be very, very long, and they're kind of unwieldy. If they're very short, they're much easier to use, but then maybe it doesn't cover everything that you think should be in there, right? So it's hard, but it's good to have a particular pattern. So yes, checklist in the manner of thinking, I'm going to look at certain things in a particular order, and I'm going to actively look for certain things. And especially if you've not come up with an answer to the scenario for that patient in front of you, like they've had surgery, they say have a right L4 radiculopathy, and you don't have a cause for it, take a moment and look and see, again, is there something that maybe you overlooked the first time through that would answer that question? I'm not saying it will always be there. I'm not saying it will always have a finding. I'm saying it's good to take a second look at it, a second bite at that apple, and try to figure those things out. In my experience, I would say the most common places to miss the disc herniation, lateral space and intraforaminal space. So those are ones I focus on as well. And sometimes disc herniations can have the same signal, maybe on T2 as other stuff. So you have to be able to focus on the T1s as well. So hopefully you're feeling good about this subject matter. I will pause there and try to answer some questions. Thank you.
Thank you so much, Dr. Mullins. Excellent talk. We have had some questions roll in if you have time.
Yeah, go ahead.
So the first question that came in is from someone who said, sometimes they feel like they're unsure if they should say that something is solidly fused. They may get pressure from the surgeon to suggest that something is bridged if they see a spicule of bone going across the disc space, in particular, like when looking at ACDFs. What do you use as your criteria to say that something is solidly fused? And before you answer that, just a reminder to everyone else, if there are other questions, please email them to emorymskradiology@gmail.com and we'll get to them.
So if I
Dr.
see
Mullins?
that the entire joint space, whatever it is, whether it's a disc or a facet joint, if the entire joint space has been replaced, then I feel comfortable saying that that's solid fusion. And I showed you guys an example of that a little bit earlier across for an ACDF. If sometimes it's only ventrally, sometimes it's only dorsally, I'll be very specific about where it is. So it's fused ventrally or fused dorsally or fused on one side dorsally, or, you know, and I'll usually say across the disc or across the facet joint or those kind of things. If somebody had partial fusion, then that's what I'll say is partial fusion. So like the spicules that you're talking about, kind of depends on how big the spicule is, but let's say that I look at it and I feel pretty good that there is partial fusion, I will say that. When I was in training, they told me to stay away from non-fusion as an expression, and so I've stayed away from it, and you know, that kind of thing. But another thing is to see how it's changing over time. Sometimes there's no change, sometimes it's progressive, you know, those kind of things. I totally understand the question and I get it. I try to only pull that trigger to when I feel very confident, and I'll feel very confident if it covers the entire joint space. If it covers the entire joint space, I feel like that's solidly fused. If it's less than that, I'll probably say partial, even if it's a little bit. I do not get into gradations of partial. And then if, you know, there's no fusion, I usually don't mention it unless they specifically ask for it, and they hardly ever ask for it per se. But as we know, that's common, right? Sometimes you see there's no fusion at all. And I don't usually mention that if there's no fusion at all.
Excellent. And Dr. Segovas, I can see you raising your hand. If you want to shoot your question to emorymskradiology@gmail.com, we'll get to that. The follow-up question to that is when or if you will ever use the term non-union or pseudoarthrosis.
Yeah, right. So I I kind of gleaned that would be a question. So I don't use the word non-union unless I'm cornered, but I can't remember the last time I've used it. So I was told that, you know, to stay away from that expression, and I do. So pseudoarthrosis, you know, lots of things can cause a pseudoarthrosis. Like, for example, you see somebody with pseudoarthrosis because of, say, ankylosing spondylitis and, you know, an Anderson lesion, and they end up with pseudoarthrosis. I mean, there are a lot of different things that, you know, you can end up with pseudoarthrosis. I don't mind that as much, although in a post-operative situation, I understand kind of what's behind the question about what it might imply is going on. I'm not as bothered by using that if I feel comfortable that it's there. And so a pseudoarthrosis obviously would be for something that looks like a joint has formed where there shouldn't be a joint, right? You know, I'm pretty simple with this kind of stuff. Try to simplify these definitions, and that's one of that I like for that one. So I will use that if I think it's appropriate and that's what I'm looking for. And but I understand what's associated with it, and I get it. But non-union is one that I can't remember the last time I used it. I mean, I never say never, never say always. It's not like I would never say it. Just said never. But it's just that I can't remember the last time I did.
Got it. The next question was about epidural lipomatosis and whether or not when you see the thecal sac compressed, if you'll call that a severe canal stenosis, or what your opinion is on the symptoms related to it.
Absolutely. And I'll call it forum fruste stenosis, right? So I'll use the expression forum fruste because it's a different kind of stenosis. Usually when we talk about stenosis, we're talking about disc herniation, osteophyte, ligamentum flavum infolding, that kind of thing. You know, maybe a tumor, you know, those kind of things. But complete effacement of CSF, to me, is a severe stenosis unless the cord is abnormal in terms of signal, and then I upgrade it to critical. I will call it that if it's caused by something else. So I've seen epidural lipomatosis be really bad. I can't remember ever seeing it to where it completely effaced the CSF, and I don't think I've ever seen it with abnormal cord signal, but I've seen it really, really narrowed. So I would call that stenosis forum fruste central canal spinal stenosis. That's how I like to use that. Absolutely. I mean, basically, the cord, conus cauda equina, exiting nerve roots, they feel what they feel. If something's pressing on them, it just makes sense. Logically, it just makes sense to me that they could feel that in one form or another, whether it happens to be, a disc herniation or osteophyte or whatever. You can make an argument that infection is different because it might irritate things more. You can make an argument that tumor is different just because it's so infiltrative, and every now and then granulation tissue could be. But for the other stuff we're talking about, it's I feel like mass effect is mass effect with those things. But yeah, absolutely, epidural lipomatosis it can cause a problem, and that's the way I like to say it. Form-fruit central canal spinal stenosis. Because if I just say spinal stenosis, central canal spinal stenosis, then people will be like, where's the disc herniation or whatever that's causing it? By saying form-fruit central canal spinal stenosis, then they understand I'm saying it's different. And basically that's it. And that's how I do it.
Got it. The next question was, do you look for preganglionic nerve injury in post-discectomy failed back surgery? The writer wrote, I find it fascinating to see these on lumbosacral plexus MR neurography, including pseudodiverticulum of the thecal sac and enlarged or compressed dorsal root ganglia at the site of injury. I haven't seen that talked about in post-op spine discussions.
Yeah, well, I think that, somebody talking about MR neurography, I think, you guys and you in particular, Adam, are better suited for that. But I will say, yes, I do look at the preganglionic nerves, the nerve rootlets, and then I do look at the postganglionic nerves, and I look at the ganglia. I look at all of that, absolutely. I mean, to optimize those areas, you'd like to have a highly resolved, like volumetric T2 sequence, but that's hard when you have hardware in place. So, I mean, it's kind of like back and forth. And so, you look to see if they're, hardest thing in radiology to see, as people say, is the absence of a normal finding, right? So you're looking at a place and you expect to find a nerve rootlet, dorsal or ventral nerve rootlet, and you're missing one. It can be hard, right? It can be a hard thing, but if you know where to look, know the levels, and remember what I said earlier, the dermatome map is ±1 in the normal human. You get the side and then get the level, and you go ±1, and hopefully you can look especially carefully in those areas. And yes, so-called empty sleeve or things of that nature, looking for a pseudomeningocele, absolutely. Sometimes trainees ask me about differentiating perineural cysts and the pseudomeningoceles, and the short version is like where you're tracing the nerve out and seeing where the nerve is, right? And another thing is it's oblong shape and looking to see kind of like its morphology. As you can tell, I'm big on morphology, but then tracing that nerve out as well. And then finally, what the clinical symptoms are. You can have phantom symptoms from if the nerve root is no longer there for whatever reason. You can have phantom symptoms, and it can be painful. That does happen, but I would say logically it would make more sense that you have decreased function in a particular area, and usually failed back syndrome is more pain. So again, statistics, are meaningless to the individual. Only important to like groups of people in a lot of ways. A person has 100% of whatever they have and 0% of whatever they don't have. So, that's what we talk about. But in general, common things being common. If you're missing a nerve root like that because of avulsion one way or another, then or cut, then the idea is that decreased function would be more typical. But that being said, you can have symptoms. It can be painful. That does occur. But yes, that's generally what I do.
Okay. The next question said, in my country, our surgeons typically follow post-op imaging, at least initially, with radiographs. Do you have any suggestion or tips with post-op following with radiographs?
I will say that in the places I've worked, the emphasis on the post-op radiographs has been to figure out if there is a surgical misadventure around the hardware. That's typically what you're looking at, right? So usually I would kind of guess that they, if they thought hardware was fractured, that they would probably have some sense of that, but maybe not always, and that's okay. Like, in terms of like it's something that we should look for anyway. So As to when they do the other imaging, kind of just depends on what they're looking for. In my experience, they will do the CT scan to try to look at the hardware, usually as opposed to the radiographs, I will say. So that's, in my experience, what it is. And as you can tell from me talking about the other images, I try to avoid, you know, I mean, if they want the MRI early for whatever reason, like the patient has new symptoms, they're worried about a bleed or whatever, you know, I mean, I can understand why they might want to do an early MR, but like I said, if you do the MR early, it can be very ugly looking and be very confusing. And so, you know, I think the X-rays are useful to look at the hardware in that regard. Don't forget, these are very vigorous surgeries typically. Orthopedic surgeries in general that I've seen are very vigorous. And so patients might end up with a fracture or something else inadvertently. So you have to pay attention to that stuff and try to figure out if that's there. I think having the X-rays is helpful in that regard as well. So I kind of understand getting some X-rays. You put in hardware, you want to see where it is. Is it covered by bone? Make sure you get the orthogonal views to figure out, like, you know, one view is no view. So you try to figure out if it's in the right spot. But as we know, the CT shows it better, right? I mean, it's just going to show you the detail a lot better as to figure out like where it is. But especially if it's close to an area like the central canal or neural foramen, it can be very hard to figure out, is it in there? Is it not in there? Like that kind of stuff. So.
Great. If you have time, I have 3 more questions for you.
Sure, sure.
The next one is, what is the optimal time frame for imaging with and without contrast to differentiate recurrent disc from granulation tissue? Is there a too late or too early period?
And so I'm going to answer it kind of in terms of time period after injection of contrast, in addition to like time, you know, like calendar time. So I don't have a number that's like too long, but what I usually tell the trainees and the techs is that, look, if something goes on, like the scanner goes down or the patient has to go to the bathroom or there's a contrast reaction or whatever, like there's something that happens. And so we don't end up doing the post-contrast imaging till much later, like maybe an hour later, then I'm very concerned that, you know, things could seep in there, right? And generally speaking, I would say the longest I would go is half an hour, that kind of thing. Most of the times nowadays, what happens is that, you know, the tech will go in and place a butterfly, inject, walk out, scan. That's usually the time frame, and you're talking like a few minutes. In the old days, we used to hang contrast and have it percolate into the patient. You're talking, you know, maybe they would scan another patient in the meantime, 15, 20 minutes, whatever, and then pull that patient back in. So generally speaking, I think that time frame's okay. If it's an hour or more, I worry about it. Maybe half an hour to an hour is more no man's land. And so it's just something to remember, that if you see something solidly enhancing and it was 45 minutes later, an hour later, that maybe that, you know, that could go either way, theoretically. So it's probably a prudent idea to say, if you want to know the difference between them, bring them back and do, you know, pre and post imaging in short succession and try to address whatever it was for that. In terms of calendar time, it can happen at any point, right? I mean, that can happen at any time. There's no great time in terms of like, you know, like in terms of months and years and that kind of thing. Now, to form granulation tissue, I'll pull on the you know, the brain stuff that we do, and people, like, what they generally say, they want patients imaged within a day, you know, so that we get it earlier than granulation tissue may kick in, like post-operative enhancement, like that kind of stuff. That seems super early, but the idea is that granulation tissue can occur very quickly in some people. It's a wide variety of how people form scar tissue. As anybody, you know, who does this stuff knows, it's like some people develop bad scar tissue, and you know, it's hard to predict, you know, who's going to have a lot of it and how fast it's going to happen. So, I mean, days sometimes can make a difference. So, you know, if it's, you know, weeks or months, then I think either one's on the differential as far as that goes. I'm not sure that there's a time period before which that I would completely discount granulation tissue. Admittedly, if it's a few days after surgery, I probably would discount granulation tissue. But, I don't know where I draw the line. Like, would I draw it at 9 days or 11 days or what? I don't know. I don't know. Maybe somebody does, but my guess is that people are too variable for that to be useful. There's such a wide variety of, like, if you think about yourself compared to other people and the scar tissue that you form versus other people there's a lot of variation to that. There's a lot of variation to that. So I wouldn't feel comfortable saying, this day or that day. But just remembering that it's a possibility, I think, is more than half the battle.
Okay, and then the last one, it's a sort of combo question that I'm rolling together, but one person asked what you think the utility of advanced imaging techniques are for telling degenerative change from infection, and then if you routinely use any of that in your practice.
Well, if I'm looking for an abscess, then I want to tack on diffusion. So that's there. Admittedly, if a patient has hardware, it's probably not going to work. But, it might not. I don't know. It kind of depends. There are ways you can do it, those kind of things. Other than that, I don't know of any advanced neuroimaging that I think is reliable in this particular setting. Trying to sort out who's infected and who's not. People have been studying this and studying this and studying this, and I think it's definitely the kind of thing which deserves this kind of study. And whoever figures it out eventually will have done a great service to the community for this kind of stuff. But unfortunately, I don't think that there's a panacea there. I don't think that there's a solution that seems very viable other than that. But there's some indications for which you might want to consider doing diffusion. I think if I'm looking for an abscess, that's that's a reasonable one to try.
Do you use chemical shift imaging to help seeing for marrow infiltration, tumor or infection? Do you think that that's helpful?
Yeah, I mean, I don't. I mean, I've seen a lot of this stuff, and the problem is, I think of it like a old-fashioned dial where you have you're trying to go between one end of the dial and the other end of the dial. And what you're doing is pushing the dial more towards one end or the other, but you hardly ever get to all the way to the end, to where it's all the way clearly infection or all the way clearly non-infection. So you're just pushing the dial more in other directions. Personally, the overlap between active acute inflammatory degenerative changes and infection, early infection, can be very significant. And even clinically speaking, I like the clinical scenario as well. One thing I've found to be extremely helpful is talking to referring physicians here and saying, do you think your patient is infected? And I think the vast majority of the time, people feel comfortable and confident about whether they're worried about infection or not clinically, about what's going on with the patient. So things like this can be helpful, like chem shift imaging can be helpful. And there are things that can be helpful. For example, looking at the cortex, right? Trying to figure out if there's a cortical defect. What about edema and enhancement next to the area? All of these kind of things. What about the signal characteristics in the disc? And there are things that help me favor infection, but I think the biggest thing is things that make you concerned about infection, and then pivoting and having a conversation with that referring physician and see if they're worried about infection. And so I think that's the most useful. Yes, these other things can be useful and you want to pay attention to it, but it's really when you're worried about it. So figuring out imaging findings that make you more concerned about it. I know what the emphasis on this has been for all the time I've been in radiology is there a way we can tell this is not infection so that we don't have to stick a needle into it? And to date, I don't know of anything that stops that, makes you feel like the negative predictive value of whatever sign is so great that, you can say it's not infection, that I get it. And as we know, sticking needles into these situations is also fraught with poor results as well, right? In general, like all comers. And so what I focus on is, do I think this could be infection? And if so, I want to have a conversation with that referring physician to say, do you think this could be infection? If I think it could be infection and they think it could be infection, then we're worried. If we disagree, then we try to figure out, what's a good way to follow it up? Do we do another one in 6 weeks or whatever? Do we do blood labs? This kind of stuff. So that's maybe a different emphasis, but I've yet to find something that's sort of a magic bullet with that.
Thank you. Well, I hope someone comes up with that magic bullet.
Me too. Me too.
It is quite a problem. All right. Well, that wraps it up for our questions. We really appreciate you taking the time to talk to us today.
Thank you.
Thank you so much. And to everyone out there, thanks so much for tuning in. We'll upload this later today or tomorrow to the YouTube channel, and we'll see everyone next week. Stay safe.
Thank you. Take care. Stay safe.
Take care.